Um, All right, Reagan, are you going to continue, or we're going to go to pregnancy and lactation? Okay,
And then we'll take a break after that.
great. All right, Sharon?
Okay, so good morning. My name is Sharon Donovan, and I'm presenting on behalf of the Pregnancy and Lactation Subcommittee shown on this slide. And like everyone else, I'd like to thank this committee for their hard work as well as the support staff. And I think we've made quite a bit of progress since the meeting in July. So today I'll be presenting new protocols as well as the implementation of some of the protocols that we presented in July, and we actually have some draft evidence synthesis, grading, and conclusion statements for 2 outcomes related to folic acid. So as a reminder, the committee is addressing 3 broad topics: dietary patterns, dietary supplements and fortified foods, and maternal diet. And these are the new protocols to be discussed today. So the effect of dietary patterns on human milk, micronutrient status of the mother and infant developmental milestones. In terms of dietary supplements, we have new protocols for B12, omega-3 fatty acids, and vitamin D. And as was just discussed, new protocols on the impact of maternal diet on food allergies. So these are the protocols that were presented in July that we're currently implementing. So in addition to the 3 on the previous slide, for dietary patterns, we're investigating gestational weight gain and postpartum weight loss. And as Kay alluded to, this gets very complicated because we have a number of nutrients of which have multiple outcomes. So I think we're doing 40 systematic reviews in pregnancy and lactation alone. Okay, so these are still to come. These are protocols in development that won't be presented today. So hopefully at our next meeting. So these are updates to the protocols that were presented in July. So in terms of dietary patterns and gestational weight gain and postpartum weight loss, we modified the inclusion and exclusion criteria for the intervention and exposure to clarify that basically what was discussed yesterday in terms of the dietary patterns, that specific macronutrient proportion diets will be included when they fall outside of the acceptable AMDR, and only studies that describe all macronutrients. Then in terms of dietary supplements and fortified foods, we had proposed in July to only cover the supplements, and based on feedback from the public, we have amended that protocol for iron to include both supplements and fortified foods. So now I'll move on to the developing the plans, so the new protocols. And I have a lot of analytical frameworks to present. So you'll see that in terms of like exposures and comparators, there's a lot of repetition. So I'm going to primarily point out the uniqueness of each one. So we can get through this a little bit more quickly. So these are protocols related to dietary patterns. So just to remind you of the definition of the dietary patterns that was discussed yesterday. So first, what is the relationship between dietary patterns consumed during lactation and human milk composition and quantity? So I'll walk through this one in a little bit more detail, but the analytical, so the intervention exposures, consumption of and/or dietary adherence to a dietary pattern compared to consumption of a different dietary pattern or different levels of consumption. So the population, in this case, is human milk composition and human milk quantity. So basically for composition, we're including women during lactation, healthy and/or at risk for chronic disease. But for quantity, we're focusing only on those mothers that are exclusively or predominantly breastfeeding, so that we can get more accurate assessments of intake. And they will be healthy or at risk for chronic disease. So we have a number of outcomes in this. This was mentioned yesterday, but we will be looking at milk collected after 14 days postpartum. So this is more representative of mature milk as opposed to colostrum. So some of the standard macronutrients, water-soluble vitamins, fat-soluble vitamins, minerals. One of the aspects of human milk minerals is that they're quite invariable. They're tightly regulated at the mammary gland, with the exception of iodine and selenium, so we're focusing on those two. We're also including some bioactive proteins where there's data. And again, this was mentioned before. So in terms of, these are, as you will see as we go through, these are a lot of our standard key confounders that we are carrying through. So I'll predominantly mention when we have additions to that. So again, we're using the standard Nesser criteria that was described by Dr. Schneemann, and we also are using the criteria for these sets of questions related to dietary patterns that are consistent with the dietary patterns subcommittee. You'll see that for a lot of our searches, we're going back to 1980 because this has not been previously included in the dietary guidelines, so we're trying to capture a broader database. But again, for this, we're only going to 2000 because, as was mentioned yesterday, this is more of a relatively new type of analysis. So these are the types of studies, again, kind of following the standard Nesser inclusion and exclusion criteria, with the exception that for studies related to human milk composition and quantity, we are decided to include some cross-sectional studies because we felt there might be insufficient longitudinal studies to address these questions. Okay, so the next analytical framework is dietary patterns on infant developmental milestones, including neurocognitive development. So again, same intervention at exposure. You can see the developmental milestones, and we're looking at this related to a couple different outcomes, and they're consistent with what Linda Snetzler reported yesterday in terms of looking at cognitive, language communication, movement, motor development, social, emotional, academic performance, ADD, ADHD, anxiety, depression, and ASD. And we're looking at infants and toddlers, birth B24, but also in this case, looking at longer term outcomes because a lot of these, particularly language development and academic performance, will need to look at later ages. So a lot of the same key confounders. We're also including aspects that have been known to impact infant cognitive outcomes, which include family history and diagnosis of neurocognitive disorders, maternal substance abuse. We also have in here things related to parity, child sex, breastfeeding practices, so duration and exclusivity. Again, standard Nesser criteria and 2000 to be determined. So the next framework is looking at dietary patterns during pregnancy and maternal micronutrient status. Again, same interventions and comparators. The micronutrient status that we're looking at in the mothers is iron, folate, B12, vitamin D, iodine, and omega-3 fatty acids. Our population is women during pregnancy, healthier, at risk for chronic disease. In terms of key confounders, we've added as a factor to be considered, not as a key confounder, gestational diabetes, because there is some evidence that the metabolism of some of these micronutrients can be different in women with gestational diabetes. Again, standard criteria here. So those were the new dietary patterns, analytical framework. So now moving on to the relationship between nutrients from supplements and/or fortified foods consumed before and during pregnancy and lactation. So we have 5 nutrients altogether. I'll talk about iron and folate later. We presented those in July, and we're now implementing those. But these are the new frameworks: B12, omega-3, and vitamin D. And for each of these nutrients, we're investigating all 5 of these outcomes. So you can do the math. Just a reminder of, again, using standard definitions of dietary supplements from ODS and fortification from the FDA. We also had to define some of the criteria. So because this is including before pregnancy, we considered the time of up to 6 months prior to pregnancy as being the before pregnancy time frame. Pre-pregnancy BMI is being defined based on health records for up to 1 year before to up to and including the first trimester, because we oftentimes don't have those measurements in health records. Gestational weight gain defined according to the CDC. And again, gestational diabetes, again, diabetes occurring during pregnancy in women not previously diagnosed, and this is consistent with what was used in the pregnancy or B24 project. Okay, so now we'll talk about B12 first. So again, we have 5 outcomes, so I'll explain the first one in a little bit more detail and then just highlight the differences. So this one is on B12 and from supplements and/or fortified foods consumed before and during pregnancy and lactation on micronutrient status. So we're looking at exposure to B12 either from supplements, fortified foods, or the combination, compared to those who are not exposed or exposed to a different level of intake. So women before and during pregnancy and/or lactation, healthy or at risk of chronic disease. For our B12 markers, we're considering B12, methylmalonic acid, homocysteine, and holotranscobalamin in maternal circulation. We're also looking at folate, hemoglobin, mean corpuscular volume, and red blood cell distribution width. And our population is women during pregnancy and/or lactation. So the standard key confounders for other factors to be considered, we're including substance abuse, alcohol or drug intake, and gestational age. We also, I can point out, as a key confounder, we have vegan or vegetarian diets in here as well for B12. So this is the relationship between B12 and risk of gestational diabetes. So these are the same. So in this case, we have intermediate outcomes, which could be reported. We're not using these as diagnostic. Basically, the endpoint for diagnosis is gestational diabetes. We have added a couple additional confounders in a family history of diabetes or prediabetes, and under other factors to consider, we have prior history of a large for gestational age infant or enrollment in an intervention prevention trial. So these data will be extracted. They're not considered a key confounder, but we are asking the staff to collect data on this. This is the framework for B12 on the risk of hypertensive disorders during pregnancy. So again, we have some intermediate outcomes, blood pressure and proteinuria. And then the health outcomes are eclampsia, preeclampsia, and gestational hypertension. In terms of the key confounders, we are added here diagnosis of gestational diabetes because sometimes these co-occur quite commonly. Smoking, history or diagnosis of hypertension or cardiovascular disease. Under other factors, we've added also physical activity to be abstracted. This is B12 in human milk composition. It's a little bit more simple. The only outcome here is B12 concentration in human milk, and we didn't have any additional confounders or other factors. Okay, this is on B12 on infant developmental milestones, including neurocognitive development. So again, these are the same outcomes that I reported previously for looking at the dietary patterns and infant neurocognitive outcome. And again, the outcomes and confounders are very similar to the dietary patterns, except now the vegan and vegetarian diets. So we've done our best to try to be as consistent, not only internally, but also as we work with other committees. Okay, so for all of the B12 analytical frameworks, again, the standard inclusion-exclusion criteria. So again, the same types of studies and continuing to include cross-sectional studies only for human milk composition and going back to 1980 for these outcomes. So now we have the analytical frameworks for omega-3 fatty acids. So these basically looking at relationship between the intake and the same 5 outcomes that I just described. So again, I'll try to go through this pretty concisely. So we have exposure to omega-3 fatty acids through supplements, fortified foods, or the combination compared to a different level of exposure. For our nutrient status, we're looking at fatty acid status in red blood cells and plasma of the omega-3 fatty acids and omega-6 fatty acids. So alpha-linolenic acid, docosahexaenoic acid, and EPA. And then linoleic acid and arachidonic acid. So in terms of the key confounders, we're including fish and other seafood consumption and obesity status. Again, there's some indication of differences based on maternal BMI, and those were the additions for the omega-3 fatty acids. So these, again, omega-3 fatty acids and risk of gestational diabetes, very much the same intermediate outcomes for the previous nutrients and the endpoint of gestational diabetes, and again, including fish and seafood. Here, other factors could be included in an intervention prevention trial in the large prior infant as well, and family history of diabetes, prediabetes. So again, consistent with the other nutrients looking at these outcomes. Again, the same, the omega-3s and hypertensive disorders. And omega-3s and human milk composition, and we're going to basically look at fatty acid composition. So not only obviously the omega-3s, but the whole fatty acid composition in the milk where available. And this is the infant, so this is relationship between, again, maternal consumption from supplements and fortified foods before and during pregnancy and infant developmental milestones. So while the B24 is going to be looking more directly at the intake of the infant, this would be potentially effects mediated from maternal diet through milk. So again, the same outcomes, including, again, breastfeeding practices, intensity and duration, so hopefully being able to pull out exclusive from partial breastfeeding. Again, same inclusion, exclusion. So now we're going to do vitamin D, again, with the 5 outcomes. So for vitamin D status, I just want to point out that the way we're looking at vitamin D status is 25-hydroxy vitamin D. In terms of, for all of the vitamin D outcomes, we've added basically as another factor to be considered is sunlight exposure and use of sunscreen. So we know that not all papers will provide that, so we didn't want to include it as a key confounder, but we do want to collect that data when possible. So again, very, very similar in terms of now vitamin D, gestational diabetes, vitamin D and risk of hypertensive disorders, and vitamin D and human milk composition. And in this case, we're trying to capture any or all of the vitamin D forms that could be reported in the human milk. And lastly, the vitamin D and neurocognitive development. So same inclusion, exclusion criteria. Just again, these are, as Kay had mentioned, available on dietaryguidelines.gov. So if you want more detail, you can certainly visit those. So the last new protocol I wanted to discuss is what is the relationship between maternal diet during pregnancy and lactation and risk of infant and child food allergies and atopic diseases. So this is just one outcome, and we're looking at, again, what is the effect of maternal diets on this. So this is very broad dietary intake of foods and food groups, either not consuming that food or a different amount of that food. So this is going to be a very broad search. Our outcomes, we have food allergies, allergic rhinitis, and atopic dermatitis. The dermatitis and rhinitis are oftentimes on the atopic march prior to diagnosis of food allergies, but we, as Kay mentioned, had some discussions about including food sensitization on its own, because sensitization alone does not indicate that that child will actually manifest an allergic reaction. So in terms of outcomes, we have timing of introduction of, our key confounders, timing of introduction of complementary foods and beverages, types of complementary foods and beverages, family history of atopic disease, and if reported urban-rural environment, exposure to animals, pets, and farms, because all of those have been implicated in affecting allergy. And again, other factors to be considered could be indoor, outdoor environment if that's reported. But we're trying to make this a very broad search because, as Rick mentioned, this is a rapidly developing area. And so we'd like to try to determine the impact of maternal diet. Okay, so again, the same types of criteria here. So that was the conclusion of all the new protocols. And so now I'd like to just talk about 2 where we've actually implemented the plan. So even though in July we had done the analytical framework for iron first, we decided to actually start implementing the plan for folic acid. So the questions that we've been investigating was a relationship between folic acid supplements from supplements and/or fortified foods consumed before and during pregnancy on human milk composition and risk of gestational diabetes. So these are 2 of the 5 outcomes that we're looking at related to folic acid. So looking at the first question. So just a reminder of this analytical framework, which was presented back in July, looking at folic acid from supplements, fortified foods, or combination on human milk folate composition. And in terms of, we really didn't have any different key confounders. These are kind of our standard ones. So we, from the search, there were 4 databases that were searched, resulting in 7,817, which was reduced to about 4,500 after removal of duplicates. After initial screening, of titles, abstracts, and full texts, we ended up with 16. And there were no new articles added. So the ones that were then included after going through our inclusion and exclusion criteria, we had 4 articles, and of those 3 were RCTs, and 1 was an uncontrolled before and after study. All 4 addressed specifically the question as what is the relationship between folic acid from supplements during lactation and human milk folate. So there were none that looked at fortified foods. So the sample characteristics of the 3 randomized controlled trials, they had on average between 14 and 23 per group. They were conducted in the US and Canada, an average age of 33 years, mostly white and high SES for 2 studies. The other study was in adolescents, mostly white and low SES. The intervention doses were 300 micrograms, 400 micrograms, and 1 milligram, and also looked at the 5-methyl tetrahydrofolate form as well. They were initiated within 1 week postpartum or 3 months postpartum, and they lasted between 12 to 16 weeks. All reported human milk folate concentrations. They also, some reported unmetabolized milk folate, soluble folate binding, milk folate binding protein. The uncontrolled before and after study, this was conducted in Japan, had of 16 mothers. There was very little evidence or data presented on the participants. They basically just said the women in the study were from the same SES group. So basically before and after, they were the same mothers. But it was a weakness of the study. They gave 1 milligram of folic acid, initiated anywhere between 3 and 25 weeks postpartum, and the trial was for 4 weeks. So the studies use slightly different methodological approaches to measure the folate, but none of the studies found an association between folic acid supplementation in lactating women and human milk folate levels. And the actual levels reported were fairly consistent among the studies. When we began the assessment, the studies were direct and precise. The results were very consistent. We had some concerns regarding risk of bias and generalization, due in large part to the populations were quite homogeneous. So again, these are draft preliminary conclusion statements that moderate evidence suggests the consumption of folic acid supplements during lactation among women in high or very high HDI, high development index countries, does not influence folate levels in human milk. No evidence is available to draw a conclusion about the relationship between folic acid from supplements consumed before and or during pregnancy and human milk folate, and no evidence is available to draw a conclusion about the relationship between folic acid from fortified foods before and or during pregnancy and lactation and human milk folate. So for these latter two, we had grade not assignable. So the second question, the relationship between folic acid and gestational diabetes. Again, the analytical framework consistent with intermediate and endpoint outcomes that I previously presented. Again, searching for databases resulted in 829 articles, which we ended up with 8 that remained after screening, and only 1 that was included in the final systematic review. It was a non-randomized controlled trial that addressed the question of what is the relationship between folic acid from supplements consumed during pregnancy and risk of gestational diabetes. It was a large study, about over 7,800 participants conducted in China, mothers between the ages of 20 and 40, non-smokers and non-drinkers. They gave doses of 0, 400, or 800 micrograms per day, and they based the dose based on genetic polymorphisms of the mothers and also the stage of pregnancy. Again, initiation was not clear because they talked about pre-pregnancy, but then they stated that they recruited the mothers during the first trimester. So as we started looking at the paper, it would have been a great paper, but there was just some concerns about the details. So among the women who consumed folic acid supplementation based on genotype and stage of pregnancy, there was a significantly lower incidence of gestational diabetes compared to women who did not consume folic acid supplements. So 3.2 in the control and 0.27 in the intervention. But when we assessed the evidence, there were concerns regarding risk of bias, and we felt there was insufficient evidence to evaluate the directness, precision, consistency, or generalizability of the results. So our draft conclusion is that there's insufficient evidence is available to draw a conclusion about the relationship between folic acid from supplements and or fortified foods consumed before and or during pregnancy and the risk of gestational diabetes. So grade not assignable. So just to conclude, we have, as Kay mentioned also with B24, we've been having a lot of cross-cutting discussions with the other subcommittees. So we've had some joint meetings, again with dietary patterns, fats and seafoods, food pattern modeling, and we also provided evidence on the analytical frameworks pertinent to pregnancy and lactation to the Beverages and Added Sugars Committee. So again, I'd just like to thank our committee. We've really, I think, made an incredible amount of progress in the last few months. And again, none of this would be done without the support staff, and just really appreciate everybody's hard work. Thank you. You don't have to.
I feel like I need to clap. That was so much.
Does anybody dare ask a question?
And we're exhausted.
And more now.
Yeah.
660 slides. Rachel.
I'm on this committee, but as I was thinking about it, I'm not clear if there's a need to distinguish or precisely what the distinction is between before pregnancy and pre-pregnancy. It seems before pregnancy gives a early start date and the pre-pregnancy gives a end window to the period, but I think they're the same definition, but what do you think?
Well, we had said, and so maybe we need to look at the precision of how we're describing it, but we did say that it was 6 months. So we're looking in terms of like the supplements and fortified foods, but in terms of like BMI outcomes, that could pre-pregnancy weight could be up to a year prior to pregnancy.
So I think in our definition we said before pregnancy was 6 months prior and pre-pregnancy was up till the first trimester, but in fact, aren't they both the same window? Whether you're referring, I mean, it's before pregnancy, what are we measuring before pregnancy? It's also BMI, so before pregnancy, pregnancy BMI, the window would be defined as 6 months prior to up to the first trimester, up to and including. And so would pre-pregnancy BMI be 6 months prior and up to and including?
Well, I think in the framework, we said that we would consider pre-pregnancy BMI up to a year, and then up through the first trimester. And I think for the fortified foods and supplements, that was 6 months, because we thought many women can be taking supplements who are planning to get pregnant, or some nutrients that could be stored in, like vitamin D or iron could be influenced. But there's so many, so I want to kind of make sure that we can be clear on that.
I guess, what are we measuring before pregnancy besides BMI, I guess is the other question.
Well, for the supplements and fortified foods, if there was evidence of use of those supplements prior to
I
conception.
see, okay.
So women who may be
I see.
prophylactically or planning to be, using advice that they should be starting to take folate and things like that.
Because I think in our key confounders, we have anthropometry before pregnancy too, and so that's where I was getting confused as
Yeah.
to how we're distinguishing
I think that
pre-pregnancy
was-
BMI and before pregnancy BMI.
Okay. Yeah, we can look at it. I think
It's-
that
it's
was
just
primarily
it's a
to
definition.
capture pre-pregnancy BMI and obesity.
Mhm.
But, yeah, I mean, if you're on the committee and it's confusing, then we definitely need to go back and make sure that we're precise in that language. I'll
Good.
make a note.
Thanks. Jamie?
Jamie Ard. One quick question on the key confounders in the analytic framework related to hypertensive disorders. You mentioned that there was the addition of gestational diabetes because of the association between the two, but there was not, you don't have hypertensive disorders in the gestational diabetes analytic framework as a key confounder.
Okay.
Would that, because I can't tell, this is not my area of clinical expertise, but I don't know if there's just a general association or if it's, sort of unidirectional, but just something to consider.
Yeah, so for the gestational diabetes, we do not have diagnosis of hypertension. So that's something we can go back and look at. I don't think it's a unidirectional. I just think that oftentimes they're just co-occurring.
Steve?
A very minor semantic comment. The word statement dietary supplements, in my world, the obesity world, has very specific meaning in a regulatory framework, which is Dietary Supplement Health and Education Act, DSHEA. And so I don't think that's what's meant by dietary supplements here, right? From what I see, these are specific micronutrient supplementation. It's not dietary supplements like with various herbal constituents and so on, right?
No, because we're specifically looking at these 5 nutrients. So we're only looking at these 5 nutrients as supplements or in fortified foods. So if they were using other, St. John's wort or
Yeah.
other things, then that's not being captured in any of our searches.
Okay.
I think the frameworks have a definition somewhere,
Yes,
don't they?
yes. We're actually using the ODS and.
Well, it's
You're
the
using
the
DSHEA
DSHEA.
definition.
Yeah.
Yeah, you're using the DSHEA definition.
Oh, it is, okay.
Yeah,
Yeah,
yeah.
I had that on
Actually, though, that reminds me of a question of, so with the supplementation, are you looking at it if it might come in with a multivitamin supplement? It's not just, or is it only
Yeah.
that they have to supplement with one specific nutrient?
Yes, we are.
It has to be,
Yeah. Yes, because many of the prenatal supplements are combined.
But
Yeah.
can I add that?
Yes.
But when we look at the evidence and the results have to be a contrast where the only difference is folic acid. So if they're getting multis, it would be multis without and multis with,
I see.
that kind of thing.
Tim?
It's very interesting. When you talk about there's so many possible comparisons between all these micronutrients and different outcomes, and some of them may not have sort of a biologically plausible explanation. So are these, and I know we don't get to ask the questions in terms of what's assessed, but is there, in terms of summarizing the evidence, how do you address that?
Great question. I mean, many of them are, we can certainly provide the evidence between sort of the omega-3s and neurocognitive outcomes and others, but again, some of them we'll just have to see how we're able to discuss that, because I would agree that it's not necessarily clear that some of the nutrients and some of these outcomes have, a clear mechanistic link.
B12 and diabetes.
Yeah.
I mean, there are many examples that
Yeah.
have no basis.
I think the sentence will start, although there is no evidence of biological
Yeah.
plausibility. We still,
Yeah.
we
No, I
still
think
look at it.
the idea was looking at sort of key nutrients and key important outcomes.
Yeah.
Do you want to specifically talk about folic acid in human milk and why we were not surprised by the results? You want me to?
Yeah.
So with the one conclusion statement we can really stand behind today is the one that the folic acid supplements during lactation in these populations doesn't affect folate levels in milk. And honestly, we knew that already from decades of work and the biology of how folic acid is taken in, and then what happens in terms of mammary gland biology. So that was not a big surprise. But I totally agree with the idea that the discussions of our sections of the report need to address biological mechanisms, as much, not in great depth, but at least allude to what we understand.
And there are, potential research questions that will come out of some of these where there isn't an obvious link,
Right.
but potentially there is some metabolic pathway that could impact it. And around folate, I think what we talked about is the absence of studies in folate insufficient mothers and whether there was.
Exactly.
Yeah,
Yeah.
so there is more to learn about this,
Right.
although we addressed this question, I think, quite
Right.
directly.
Yeah, so our conclusion statement very specifically says in high HDI countries, so we can't conclude whether it would be beneficial in women who are folate deficient, and also the addition of folate to the food supply through flour has kind of raised everybody's, but nobody's really specifically looking at that anymore because it's there. So, that's why we tried to think maybe there were some older studies prior to the fortification. But
Yeah.
So maybe it would be helpful to just clarify that in your language, because there are high development index countries that don't have fortification.
Right.
So maybe just in countries with fortification, or in folate replete populations, or something
Mhm.
like that,
Okay.
might be just adding a little clarity.
Yeah,
Okay.
that's a good point.
Yeah, I think in terms of our statements, we're trying to work with a common language, but, in our discussion, we can provide more evidence and flesh things out a bit.
Yeah. Any other comments or questions? Oh, Reagan.
Just a quick question. So I'm really interested in the research on the quantity of human milk. What does that literature look like? Isn't there tremendous diurnal variation, and how are you guys addressing that? In addition to all the amazing work you're doing, you have a lot of challenges inherent within each of
Yeah.
your questions, so.
Right. Well, we haven't gotten to any of those searches yet. I mean, there's several ways to measure milk quantity through 24-hour weighing or stable isotopes. So we would try to look at the methods that are being used, and then, when we're grading the evidence. But yeah, I don't think that a lot of these micronutrients will have much of an effect, but it actually might be interesting when we get to the beverages, potentially. Just fluid intake.
So speak up.
I would be
Speak
happy
into
to.
the
So we've understood for a while that the regulation of milk production is governed by endocrinological factors and physiological factors, but mostly driven by infant demand. So maternal nutrition is a very minor player, and particularly in well-nourished populations. And if it is a player, it's more on the level of energy balance and those kind of really macro and micronutrients we don't know of. I don't know of any mechanisms by which their intake would affect those mechanisms that determine milk production. Again, the biology here is what we really need to look at. And it's interesting because in dairy cows, it's different, and maternal nutrition of the cow can make a difference, but they've been bred for very high levels of production, way beyond what human women do. So it's a very different situation. We don't really have a great model from the animal literature.
I thought where you were perhaps going with that also is there are differences in concentrations in human milk depending upon when the milk is sampled. Is that what you were getting? Yeah.
Yeah.
And so
Yeah.
one further need for our group is to be sure that the methodologies for collection are similar between studies, right? Because if you're collecting early in the lactation or at the end of it, or it happens to be at night versus the morning, or
Right.
it's early in the lactation cycle versus very late, and we could go on and on.
Right.
So and sometimes the studies don't actually talk about that at all, and so that makes comparisons even more challenging.
Yes, so one of the decisions we made was milk after 2 weeks, so to try to get some of the colostrum. But you're 100% correct that if it's fore milk versus hind milk are different times of the day, so that would be considered as the evidence is being abstracted, and we can look at that. If it's a single sample, and they don't define when it was taken, particularly as we start looking at some of the omega-3 fatty acids and fatty acids, since those tend to be higher in the hind milk.
Mm-hmm.
So, very good point, Ron.
Yeah.
Actually,
Sharon?
Tim had a,
Further question.
One more question. You guys are trying to distill out the effect of supplements, and so I was just wondering, in the protocols, I might have missed it, but how do you try to account for, baseline consumption of a particular thing, such as folate, apart from the supplements? Is it possible to do that, and should that be kind of a key confounder for all of those, for each of the micronutrients?
Well, I think from the dietary, from Reagan's committee, we'll be getting levels of intake. So we can speak to that more generally, but unless in those specific papers they did any sort of a diet record, I think it'd be very difficult for us to determine, the intake within a specific study. But we will have intakes of these nutrients, from NHANES and other data sets.
but
And-
it also comes back to this point that in a country that fortifies, chances are you have a pretty high level of intake.
Well, one of the things we thought about is, almost gets back to dietary patterns. As people are, consuming less carbohydrate, that is a large contributor to folate intake. So, if we look at dietary patterns, we might actually see differences in folate consumption, which, could be problematic. Okay.
Linda?
I just wondered, and I don't know how this plays into the equation, but many moms today will pump, and you had mentioned the idea of demand and how important that is. Are there any studies that have been done looking at that concept?
Yeah, you can actually increase the stimulus for milk production by pumping in addition to nursing directly at the breast. The body interprets that as increased demand, and will respond to that. So, yeah, it gets more and more complicated these days because so many women are pumping.
And then we'll also take into account if it was pumped milk, if it's been frozen in terms of nutrient composition.
Sharon?
In the analytical framework for vitamin B12, and I think for other key nutrients, supplements, you put into the key confounders vegan/vegetarian diets. I mean, I wonder as far as using this as a confounder. And the other thing, in case, I mean, that is one to proceed, I think it will be wise to separate, I mean, vegan versus vegetarian diets, if by vegetarian we interpret lacto-vegetarian.
Right. Certainly, that's a good point. So right now they're combined, but that data would be abstracted separately. So we'll be able to look at those separately.
If I could just add, I think one of the important considerations as it being a potential confounder is that many pregnant and lactating women who are at least vegan and maybe even vegetarian are advised to take vitamin B12. And so the consumption of supplements and the dietary pattern are linked quite strongly. So that's why it's an important confounder in my view, because when we're looking at the outcomes, we have to figure out what they're related to.
But beyond being a confounder, I mean, it could be also an effect modifier.
It
so,
could
I mean,
be.
Stratifying by this parameter will give very useful information.
Absolutely, but we're dependent on the studies to have done that. And we think it's a logical thing to do, but it isn't always in their papers.
All right, well,
I have a question for Linda. Can I ask that? So I have a question for the Dietary Fat and Seafood Subcommittee, because I was looking back over all of the protocols we just presented this morning, and in terms of the omega-3 fats in the beta-24 protocol, so we're looking at intake of that from supplements or fortified foods. But the outcome domains do not include neurological or cognitive development. That's what we were given. So my question is, I don't remember what is the definition of the types of dietary fat exposures that your subcommittee is looking at. Does it include supplements or exclude supplements?
What I presented the other day excluded supplements. That doesn't mean that some of our eventual questions might not get into that area. When we look at total fat, for example. But what I presented with ADD, ADHD, and ASD excluded supplement.
Because they were seafood questions.
right, just purely food.
So perhaps we can discuss this when we have some crosstalk on
Yes,
the upcoming
most definitely.
protocols. Thanks.
Most definitely.
All right, well, I think we've earned a little break. So 15 minutes, is
Yeah,
that?
I think 15 minutes.
Okay.
And just before we go on break, I do want to once again remind everyone who's listening that what we're hearing from the committee reflects their findings and their conclusions. We haven't formulated any recommendations yet, so these are sort of our initial findings and conclusions that we're presenting for discussion.
Work in progress.
Yeah, so what
All right,
about?
10:55?
Yeah, sounds good.
Great.
Great.